Hi guys, Dr. Douglas Gillard here once again. This is a makeup lecture. I was not feeling the greatest today, so I'm going to do this one via YouTube for you. And here we go. It's a dermatology makeup. This is week number 9, by the way. And here we go. Let me turn on my little laser pointer. There we go. So, talking about scales. We haven't covered that yet, really quick. And then the big ones today are seborrheic keratosis, very common skin condition. Then actinic keratosis, which is a precancerous stage of squamous cell carcinoma. So here we go. Talk about scales first. AKA, these are also called squames or desquamation or flakes. Different authors use different preferred terms. The big ones are scales and squames, same thing. And they occur when large regions of dead corneal sites. What's a corneal site? That's the top layer of the skin, the stratum corneum cells or corneal sites. It occurs when large regions of these things stick together and then they lift off or flake in the epidermis, and they so many of them stick together you can actually see them with the naked eye. There's many causes of these things. Just a few of the conditions. Dandruff is a form of squame. That's called pityriasis form desquamation. And then we have psoriasis form, which is psoriasis is another, may present with squames. Eczema could present with squames, small laminar desquamation. Exfoliative desquamation, scarlet fever is classic for having the skin corneal sites clumped together. And then ichthyosis, ichthyosiform desquamation. This is a condition classified or that occurs when the patient gets Ichthyosis vulgaris, or kind of the fish scale disease. So let's take a look at that here. In a second. Some more just in general about scales. Normally the process of desquamization, remember this, the layers of, remember keratinocytes are born down in the at the bottom of the epidermis, and as they're born by stem cells, they are ratcheted up. They get pushed up and up and up. So you have a conveyor belt of cells pushing up. When they get to the corneal site, become corneocytes, they die and they slough off. Normally, you can't see that sloughing, but with scales, they're stuck together so you can actually see them with a visible eye. Here's a little guy with scarlet fever, and these are perfect examples of scales or squames or whatever you want to call them. We'll call them scales. Okay, so this would be called an exfoliative desquamation, secondary to scarlet fever. Ichthyosis vulgaris, let's fall down a rabbit hole and talk about that a little bit. This is by far the most common genetic form of ichthyosis. It is passed on by your parents. It's an autosomal dominant disorder. It's all it takes is one mate. Autosomal dominant means all it takes is one mutated gene from mom or dad and you have the condition. The true prevalence is not known because many people have milder forms of it and they don't look like fish scales so much, so they never bother to go see the dermatologist. But it's estimated about 0.3% of the population, so not super common. More common than Marfan syndrome though, which is 0.01%, so much more common than that. Typically shows up in late childhood, super dry skin, but they look like fish scales, as we'll see in a minute. It tends to get better with age, so the kids can grow out of it. Worse in the dry heat, like when you turn your heater on in the winter, it dries out the air, so that worsens not only ichthyosis vulgaris but all types of dry skin disease, which is called xerosis. Commonly, I shouldn't really say it's a disease, it's so common, almost all elderly people have it. The ichthyosis vulgaris typically affects people in the lower legs first. And the presentation, it classically presents as dark brown fish scales. It literally looks like the patient has fish scales. And that may or may not be on a background of xerotic skin. Usually the skin is dry and then it starts clumping together into these fish scale things. They can present as plaques or papules, but typically it's these fish scale-like things. Here's a perfect example of it. Looks like fish scales. You've probably seen someone like this. There's another one, a little more pronounced. This is a patient with Ichthyosis vulgaris. Another one. You can see it on his thighs, on his legs. Okay, now it's not a dangerous disease in and of itself, but there are some associations. The patients who develop Ichthyosis vulgaris, like this guy right here, he probably has, he doesn't have it himself, somebody in his family or his mom, his dad is probably atopic. So there's a history of atopy in the family. A lot of people ask me this in the midterm. Is that a spelling mistake? What is that word? Atopy is a condition that you can have, and it means that you have three common problems. You have allergic rhinitis, meaning you have a runny nose all the time. You're allergic to the springtime, the fall time. You're allergic to dust, just allergic to everything. Then you have asthma, and then you have atopic dermatitis. That's atopy when you have a history of at least these three things. Okay, and they often have concomitant KP. We talked about keratosis pilaris already. Those are the little look like goosebumps. 50% of people also have concomitant atopic dermatitis, right? Which makes sense since they have a history of atopy. And often associated with a palmar or plantar hyperlinearity. So this is just, if you look at your own palms right now, you see the lifeline and the different lines, but you don't have like crazy lines all over your palms. Hyperlinearity means you have lines all over the place. See, look at your palms. Your palms don't look like this. That's hyperlinearity. There's another one, an African American. Okay, that's a close-up, lots of lines. Your palms don't look like that. Yours are smoother. Okay, what's the etiology of Ichthyosis vulgaris? They think it's got to do, we talked about filaggrin a lot and how important that is with the barrier function. Remember, your skin is has a good barrier, it's waterproof, so to speak. It doesn't let water in or let water out. It doesn't let bugs in or bugs out. Its normal skin is very tough. But some people lose that barrier function, and then their skin is not so tough. Remember, underneath your epidermis is your dermis, and that's where your blood vessels and lymph system is. So if you get bugs into your dermis, you can get sick, you can get infection, all sorts of things. We talked about conditions where things can penetrate a weak barrier and cause all sorts of eczema all over the hands, atopic, or the contact dermatitis. Remember that one? If you have a strong barrier, you won't get contact dermatitis. All that means is that allergens, things that are going to set off the immune system and inflammation, they get through the epidermis, which they're not supposed to do. So, all right. So mutated filaggrin. Remember, filaggrin, of course, it holds keratin fibrils together and that makes it really, really thick. The barrier, I won't get into all the biochemistry of that. We talked about that already. So patients with Ichthyosis vulgaris, therefore, if they don't have a good barrier, they're super susceptible to contact dermatitis. So allergens can really easily get in. Latex, whatever. Okay. Out of the rabbit hole, let's finish up scales. Commonly seen in people these people can show up with scales: xerosis, psoriasis, ichthyosis, scarlet fever, syphilis, Kawasaki's disease, seborrheic dermatitis. There's another person with lots of scales. They can have different colors. Psoriasis scales are silvery white. Uh, Seborrheic dermatitis tends to be a little more yellowy. We'll look at some, well, we've already looked at some of these. All right, so that's finished up another term called scales. Now let's get into SK, Seborrheic Keratosis. It's the great malignant melanoma imitator. This guy has many, many different presentations. It's easy to pick out when it looks like this is his late phase. The earlier phases aren't so easy. So let's talk about it. I commonly just call it SK, a lot of AKAs. Verica seborrheic senalis, senalis keratosis, seborrheic warts, seborrheic verica, which is, those are the warts that the HPV virus on your hands or in your feet, bottoms of your feet, or same type of virus is a sexually transmitted virus as well. It can be look like that a little bit. That's why it's named that. It's the most common benign cutaneous neoplasm of the skin. Okay, what does that mean? It's benign, meaning it's not cancerous. It usually doesn't turn into cancer. Cutaneous is skin. Neoplasm is new growth. It's pronounced seborrheic, so seb or eic, seborrheic keratosis. Many different faces. It can present many different ways. There is some heredity to this. Your mom and dad have it. You probably can get it. Usually it doesn't show up at your age, but once you get into the 30s, some of you are in your 30s, then you can start to show up. But older people can have hundreds of these things. They start showing up in 60, 70, 80 or so. A lot. Here's a classic presentation of typical seborrheic keratosis in some different forms. So when it gets this kind of, I don't know, brainy look, looks like the brain, a little brain, I guess. I don't know how else to describe it. That's classic seborrheic keratosis. And what else we got here? There's some different phases of it. Sometimes it's got this waxy appearance, like wax, or a greasy, waxy feel and look to it. So that's it. We'll show you some other presentations too. What causes it? They don't exactly know what exactly causes it or what goes wrong. It's not cancerous. Sometimes lentigo, we talked about that. So in fact, did we see some lentigo in this patient? Lentigo looks exactly like some of these. I don't really see lentigo, but lentigo is a brown colored macule, so it's not raised, it's not waxy, it's not rough on the top. But sometimes lentigo lesions can progress into this, according to Norman, 2012. Microscopically, if you look under the microscope, it looks like a lot of little tiny warts that are growing. I guess you could say these kind of look like warts, but they're not. You go in there and you do a culture of it. There's no virus in there. There's no HPV virus, so that's just kind of a look that it has. And again, typically it's not a dangerous thing, but cosmetically it can be a problem if they're all over your face and everywhere. So luckily it's pretty easily taken care of. It doesn't hang to the skin very tightly. Here's another patient with these lesions. So they're raised lesions, papules. A lot of these are plaques. They're bigger than 1 centimeter. They're brown. Okay, typical presentation. You can see them on the trunk of the body, underneath the breasts. You can see them. They can also be seen in sun-exposed areas like the face and the arms, the neck, the hairline. Typically start out as small little tan lesions, but as they grow, they can get kind of ugly looking and more warty-like. I think we got a slide in there. Oh, here we go. So here's the presentation in your 50s or 40s or 30s when they start developing. There'll be a raised little plaque. But as you get older, they start getting worse. They get more lumpy, bumpy on the top. And then in their full form, they look downright gross. They look like those little brains, like little warts all over. So they're very easy to pick out. They're not so easy because they look like they can look like just regular. Well, I don't want to say freckles, but they're harder to pick out when they're more macule-like instead of plaque-like. And I was thinking when they look like lentigo when they first start. It's kind of tough to tell them apart from lentigo. Again, we said that large ones have that waxy or greasy feel to them. It almost looks like a drop of wax on the skin, or they have a stuck on like they're fake. Like you can scratch them off, and you can. They don't stick very strongly. They're usually not painful. They can become, if you bump them or pull on them, they can get a little staph under there, and you can get an infection. Here's a SK lesions. They literally look like drops of wax here. Now there may be some lentiginous lesions, some lentigo lesions, maybe the lighter brown ones are mixed in with these. Here's one that has become infected. Staph has gotten under there, and now it's an infection going on. Therefore, they're not that brown color. They look red and inflamed. It still looks like a drop of wax, though. Here's some other ones. Somebody's been scratching at them, or somehow a couple of these got injured and staph got in there. So now they're inflamed. Surface characteristics, we talked about, they're usually that tan, black-brown color, but they do have a tendency to become variegated, and that we talked about the dangers of variegated lesions. That is a malignant melanoma looks like that. So therefore you have to be really careful with these things. In fact, sometimes they can have irregular borders, notch borders, variegation bigger than 8 centimeters or 8 millimeters. They break all the ABC rules. So you have to refer them to the dermatologist if you see them. We'll show you some ones you really can't tell apart from malignant melanoma or even basal cell carcinoma. Okay, if they only have that tan appearance when they're first starting out, that's easy, but you can still get them confused with lentigo or even AK, actinic keratosis. They have a more yellow tint, as we'll look at those in a minute. So here's a lesion greater than 6 millimeters. That's probably 8, 9, 10 millimeters across. What would you do with that one? You'd have to refer it out, right? If it's bigger than an eraser tip, if you can't fold it in half, it's all funny shaped. And if it's variegated, we got dark brown here. Variegation means different colors, like multicolored, aka variegation. Light over here, kind of even white over here. You got to send that out because melanoma, malignant melanoma, can look just like that. This one turned out to be SK, seborrheic keratosis, but you can't take that chance. Almost all humans get one of these at one time in their life, typically less than 20 of them. They can occur anywhere except on the non-hair-bearing surfaces, so they don't occur on glabrous skin like the lips, the palms, the soles. Surface characteristics, again, the key finding is that kind of stuck on to the skin look that's waxy or greasy. Remember, the lentigo lesions don't look like that at all. They're flat macules. So that's how you can tell them apart from lentigo. And they don't, histologically, they don't make it into the dermis. They're very superficial. Therefore, you can scrape them off real easy. Some people say they look like barnacles. Here's barnacles. They get stuck to a ship's hull or rocks. And they look like they can be pulled off easily, and they can come off easily. Now, what is this? Here's your 3 o'clock patient. He says, "Doc, what is the deal with all these little bumps all over?" Is that SK? No. That's lentigo, right? Light brown in color. They're not raised. You can see they're smooth. That's just, sometimes they call it solar lentigo. It's not SK. How about this one? It's a breast here. Usually right under the breast, they like to where that sun hits when they're sunbathing. Now those are raised, some of those. See, that one's raised, that one's raised. That's seborrheic keratosis. Might be some lentigo in there as well. That is flat, but they often come together. Here's some more advanced ones. Here's one that looks really waxy, but you see the rough surface. That one looks like melanoma. It's variegated, can't fold it in shape. So those are both SK lesions, but can't tell the difference. These look more sinister, don't they? But they're really easy to diagnose. That looks like a little brain, I guess. But they're really warty-like. That's classic SK that's been there a long time. Sometimes you can have smooth appearances. Okay, that looks scary, doesn't it? That's really coarsely variegated, light brown, dark brown. You can fold it in half though. But that still, if you ever see something like that, you need to refer that out to the dermatologist. This one's irregular borders, that's greater than 6 millimeters. This turned out to be SK, Seborrheic Keratosis. Sure looks like malignant melanoma. But these little, see these little white little bubbles in here? That's something the dermatologist will look for to tell that it is not cancerous. But don't you ever try to do that by yourself. And if public is watching this video, anytime you see a lesion that's you can't fold it in half, it's got two colors, it's got dark and light brown, you got to send that patient to the dermatologist. It could be cancer. Cancer can kill you, right? Here's another one, really looks like a melanoma. Can't fold it in half. It is variegated, light brown here, dark brown in the center. There's a couple of those little weird white pearly soap bubbles, which tells us it's not, it's SK, but again, that's, as far as you're concerned, that's melanoma, malignant melanoma, until proven otherwise. What about this weird looking thing? Well, it's got that waxy look, but this one's really yellowy. So we're going to talk about actinic keratosis in a minute. Sometimes actinic keratosis can even look like AK. This one is actinic keratosis. Or no, this one was AK. I see, it even fooled me. It looks like actinic keratosis. Oh no, this one is actinic keratosis. What am I thinking? Yeah, it didn't fool me. That's too yellowy, and we'll see that this is coming in a minute. There's classic SK lesions. Okay, this one's tougher, right? This one's easy. They're lumpy, bumpy, they look kind of warty. That one, I don't know about that one. If we blew it up, it'd be variegated, and it's way bigger than 6 millimeters. That one you'd have to send to the dermatologist. It's all by itself. It looks suspicious for malignant melanoma. What do you do for these things? They're not dangerous. Get them checked by the dermatologist, though, to make sure they're not cancerous. And you don't have to do anything with them. If they're gross and they bug you, you can easily remove them with something called curettage. They inject the area with a little local anesthetic and scrape them right off. Gross picture warning. Courtesy of our DO friend here. But you literally, that's a sharp little blade there with a loop, and they literally scrape the things right off, and they don't come back. They don't bleed that much. All right, bad one, squamous cell carcinoma. So this is mutated cells. The cells of the keratinocytes have went crazy. They are not dying like their apoptotic mechanisms have been turned off, so they don't die and slough off like they're supposed to. So they accumulate. And they start to form a mass. That's any cancer, you could say. But these are cancer or mutations of keratinocytes, have nothing to do with melanocytes. So the mutated cells, in order to have cancer, these keratinocytes had to breach into the dermis. All right, so that's cancer. About 20% of all cases of skin cancer, so that's a big chunk. Second most common form of skin cancer, basal cell carcinoma, is the most common. Incidence has been on the rise lately. We're not sure why. Thinning of the ozone. Another one is UV radiation. A lot of the sunblock doesn't take out UVA. It only takes out UVB. And so people are getting exposed to more UVA, which is thought to now cause cancer, especially tanning beds. So if you get a sunblock, make sure it protects you from UVA and UVB. Lifetime risk of developing it's about 10%. So 1 out of 10 people is going to end up with squamous cell carcinoma. Risk factors, it's all about the sun. The closer you live to the equator, the more chances you have at getting squamous cell. In fact, somebody did a study on this out of Hamblin. Reference 5, every 10 degrees of latitude that you head toward the equator, it doubles the risk of you getting squamous cell carcinoma. Diagnosis, the average age is about 72. Its aggressiveness which means its ability to get into the bloodstream and lymph system and kill you. Remember, if it just stays on your skin, it's not going to kill you. Your skin doesn't really care about it, but if it gets into your blood and spreads to your liver or your heart or your brain, you're in big trouble. That's aggressiveness. So the aggressiveness and age are directly proportional. What's that mean? The older you get, the more aggressive it gets, the more chances of metastasis it has. Males are at much greater risk than females. Unlike basal cell carcinoma, the cutaneous SCC is associated with a substantial risk for metastasis. So the skin form, which we're going to look at, of squamous cell carcinoma, it's more metastatic. It's got a higher chance of getting into the lymph system. Basal cell carcinoma usually isn't that big deal as long as you get it treated. This one you can't mess around with. You can't miss these. It's not as bad as malignant melanoma, though. But it's so much more common than malignant melanoma, it can still kill people. Most of the time, it shows up on their head or neck, 75% of the time. Again, likely secondary to UVB, and now they think in UVA radiation as well. So typically much more aggressive if it shows up in the face, in the head, and the scalp and neck. Let's meet it. Let's take a look at it. So this is like nothing we've ever seen. It's usually an erythemic base, so it's on a red background. It can look a lot like AK, actinic keratosis, which we didn't talk about yet. That's the preform of it, but it's got yellow in it. You see yellow and red, especially if it's flaky. That's cancerous to me. Squamous cell carcinoma. So you need to get that over to dermatology just ASAP. There's two risk groups. You can break it down a little bit. Those who experience chronic UV radiation from tanning booths and UVA, I should add in there as well. Tanning booths in the sun. If you get cancer from this, it's more likely to be an in situ type of cancer where it doesn't spread. The ones from radiation, if you've had radiation therapy or burns or chemicals, exposed to chemicals, you work with chemicals and burn your hands a million times, or if you have chronic ulcers like diabetic who gets ulcers all the time, and you end up getting squamous cell, these are very metastatic. They're highly aggressive, and you have to be very careful with them. Other risk factors, the obvious fair-skinned individual, blue eyes, hazel eyes, and red hair, much more likely to get skin cancer, any type of skin cancer. Those who like the sun, live close to the equator, outdoor occupation, like to sunbathe. Those have used PUVA therapy, so that's with A. You still can get it. There's now a risk factor with that and the use of Sorilin. We talked about that, but they're at risk. Patients who've had genital warts seem to be more at risk, where the lesions in the genitals can become cancerous. Chemicals, we said about that, radiation exposure. AK, which we're going to talk about, actinic keratosis, much more likely to get for that to turn into a cancer, squamous cell carcinoma, than the average human. And in fact, about 18% of patients with precancerous actinic keratosis, it turns into cancer. That's a pretty good sized number. Patients that are immunosuppressed, it's well known that they're at risk for squamous cell carcinoma. 65-fold increase. Favorite target, likes the lips, the scalp, the ears. Anything where sun gets hit, sun-exposed regions, face. Basal cell carcinoma also likes sun-exposed areas, but it doesn't, for whatever reason, basal cell doesn't hit the scalp and the dorsum of the hands and the top, the pinna, the rim of the ear. Squamous cell carcinoma loves the scalp, the dorsum of the hands, and the superior surface of the ear. Oh, I can hear a question coming on that one. That's a good exam question. Clinical presentation, it can be quite variable, but in general, it can be papules, nodules, ulcers, or plaques, varying types of texture and color. The lesions are often superimposed on redness, so erythemic base or an erythemic background of skin, and it could come from actinic keratotic lesions. But you can touch them if they're painful. That's a bad sign. We'll look at what they look like. But yellow flakes is the buzzword for actinic keratosis. Here's one erythemic background. See the red around it, and there's a raised lesion on the hand, almost a nodule-like looking thing. That's squamous cell carcinoma. Here's another one. So this is very similar to actinic keratosis, AK, where you have these yellow flakes, but now we've got a spread of erythema around it. That's cancer. That's squamous cell carcinoma. Here's another squamous cell carcinoma lesion. This one's really red. It's the first type of cancer we've looked at that's got this red appearance, and it's on a red background. There's another one. It looks quite a bit like AK, so we'll see AK in a minute. Telangiectasias kind of around the area as well. That's squamous cell carcinoma. Another one. Here's the back of the hand. There's the knuckles. Remember, squamous cell, basal cell doesn't like the back of the hand. Squamous cell loves the back of the hand. And again, there are these AK-like lesions here. There's a lentigo lesion right there. See the flat? Lentigo likes the back of the hand, light brown. But, yeah, that's not good. Squamous cell carcinoma. What about treatment? Cryotherapy is used for the ones that are smaller, more superficial, and aren't the ones that are at risk for getting into the lymph system. For the bigger ones and the ones that are more dangerous, you got to surgically remove them. It's a big surgery. You have to go way down into the dermis, even the subcutaneous tissue. So it's going to leave a pretty bad scar. But that's the gold standard. Okay, excuse my cough here. Because I'm not coughing as bad as yesterday, which is good. Anyway, so AK, actinic keratosis, this is a precancer. This is precancerous to squamous cell carcinoma. Let's talk it over. So precancerous condition, some AKA solar keratosis, senile keratosis because it happens in older people, solar because it happens in associated with the sun. Don't like these AKAs. Bologna, which is a book I really like. It's too bad it's getting close to $400, but I'm actually putting more and more stuff. It's very evidence-based. Rook is the best one though, but I think it's close to $900. So Bologna is going to be our new book. I really like it. Anyway, I digress. So it's a precancerous condition. They don't like to call it solar keratosis because look at the initials SK, seborrheic keratosis. It gets confusing, so authors shouldn't call it that. Actinic keratosis is better, keeps it separate because it's way different in seborrheic keratosis. It's a precancerous condition. It's a precursor of squamous cell carcinoma. One of the most frequently countered lesions that you run into in clinical practice. People are scared of this one. It doesn't look good. There's several subcategories. We could really dig into it, like Bologna does, but I'm not going to dig into it that deep for us. So keratinocytes are mutated, just like in squamous cell carcinoma. But the difference is they're growing wild, they're crazy, but the difference is they have not went into the dermis. They're still isolated in the epidermis. So that's the difference between. If they get into the dermis, now you have the diagnosis changes to squamous cell carcinoma. As long as they're in epidermis, they're just actinic keratosis. They're found over sun exposed regions, of course. One weird thing about these is sometimes they disappear completely, and then they come back. None of the other lesions we've talked about do that, but this one does. And it can come back years later in the same place. So they're a little strange. About 10% of the AK lesions will transform into squamous cell carcinoma in 10 years. About 18% will convert in the lifetime. That's from other research. If the lesions become tender to palpation, bad omen. Make sure you get them to the dermatologist. That's a sign that they could be cancerous. You shouldn't be able to palpate them. That shouldn't cause patient pain. Etiology, we do know something about this. I'm trying not to go too crazy into etiology just every now and then, but there is a gene, the TP53 gene mutation, that is well known to cause this. And it's thought that the sun damages the DNA in the keratinocytes. Specifically, it damages the TP53 gene, and that TP53 gene makes a protein product, like all genes actually can go through the central dogma and produce a protein product called P53. P53 is found mutated in about half of the people with AK, but the mutation is found in 80% of the patients with squamous cell carcinoma. So that's a pretty strong indicator. It's not a perfect story, but so mutation with the TP53 gene from sun damage is probably the cause of this. So what does all this mean? What is the P53 protein? It's a tumor suppressor that I'm sure you learned about in your genetics classes. Tumor suppressors, they're like patrols. They patrol the DNA and look for damage in the DNA. And if the damage isn't too bad, they can call in machinery to fix the DNA. If the damage is really bad, they can call in the troops and turn on the apoptotic clock and destroy the cell, which kills them in the process. So that's the story. Now, they typically, the presentation, yellow is the key word. They have several different presentations, but a yellowy, scaly crust on the skin, that's not a good sign. I mean, it's probably okay. It's probably just AK, but you got to be careful this one because it could be, or it could turn into cancer. They're typically kind of oval in shape. We'll look at a bunch of them here in a second. Now, these lesions are very adherent. They dig deep into the epidermis and very close to the dermis. So if you try to scrape these off, it'll bleed like crazy and it'll hurt like crazy. You can't just scrape them off like SK, seborrheic keratosis. You just scrape the things off, no big deal. You have to differential diagnosis with these, though. Squamous cell carcinoma can be really tough. Sometimes they look like seborrheic keratosis. Sometimes they even look like lentigo, malignant, which, did we talk about that? If not, we will. It's a precancerous form of melanoma. We did talk about that already. Lentigo malignant melanoma is a form of melanoma. Okay, let's look at some. Right, you never seen anything like this. So there's the yellow flakes. That's what we talked about, flakes today, or squames. And this is a pre-skin cancer. This is a pre-squamous cell carcinoma. So probably not a big deal, but for you chiropractors and physical therapists and primary docs, refer these to the dermatologist and let them deal with them. Why? There's no chance of you getting sued because one of these really with squamous cell carcinoma. You can't tell them apart, so you got to refer these things. Let the dermatologist deal with it. It's another one. Not much yellow on this one. It looks more like squamous cell carcinoma. There's a little bit of yellow here and there, but this one was SK. It wasn't. It wasn't carcinoma. Okay, classic, right? Almost like a yellow. It's yellow, big plaques, and flakes here. So classic SK lesions. Bad omen. So if they're really thick, bad omen. Really thick on the bad place too, right on the rim of the ear, getting hit by lots of sunlight. They have a much greater chance of turning into squamous cell carcinoma. If the lesions start oozing like juice out of them, bad. That means squamous cell carcinoma it's probably already cancerous. Here's another AK lesion. Okay, risks are exactly the same for squamous cell carcinoma. So any outdoor risks, golfers, mountain climbers, deep sea fishermen, you name it. Management, If you do, if you go to the dermatologist, they biopsy and they say, no, it's not into the dermis, so it's not cancer, it's precancer. These people need to stay out of the sun. Even if they, I mean, they should always use sunscreen that has UVA, UVB. You can treat it with some retinoids, uh, diclofenac gel can be tried to kind of get the redness down and maybe take it away a little bit. Facial peels can work. There's laser surgery. These are more cosmetic. Remember, you got to make sure it's not cancerous before you start monkeying around with it. Curettage cannot be used. You can't scrape it off. It'll rip it and bleed and hurt. So it's a little tougher to manage. Let's see if you learned anything. What is this? Well, you're going to refer anytime you see yellow flakes. Uh, but this is SK, seborrheic keratosis. This did not turn out to be squamous cell carcinoma. That turned out to be squamous cell carcinoma. So that's got to be referred. It's red and it's got a little yellow. It looks just like that lesion I showed you under squamous cell carcinoma. Yellow flakes, see them all? Nope, seborrheic keratosis. This one was not cancer. I think we already saw this one before. That's squamous cell carcinoma. It's red. There's a little yellow. Probably started as a SK lesion. But no, that's a bad one. This one, that's a little trickier one. You can see it's inside of a scar. It's actually the reoccurrence of squamous cell carcinoma. But it looks like seborrheic keratosis, doesn't it? So that's why you got to refer to these ones. All right, thanks for listening. We'll see you next week.